Okay, we are ready.
Okay. Good evening, everyone. Welcome to the November 10, 2022 meeting of the Community Board 6 Health and Human Services Committee. My name is LV Barroso and I'm the chair of the committee. This meeting is called to order at 6:38 p.m.
There's something you're looking for?
Yeah, I lost my...
See if you can find it now.
Okay, so tonight we are joined by Assistant District Manager Brandon Burt. As a reminder, New York state law now requires all community board members to have their cameras on and their first and last names displayed from the time the meeting is called to order until the time the meeting is adjourned. If your camera is not on and your name not properly displayed, you cannot count towards quorum. Members of the public, you can raise any questions or comments that you have through the Q&A feature of Zoom. If there is time following the committee's discussion, we will field questions from the public. Tonight, Aisha is taking the minutes. Thank you so much, Aisha. And now Brandon will take attendance by roll call.
Committee members, I will call your name and you will unmute yourselves. When your name is called, please say present. I will announce if there is quorum. Marty Barrett. I do not see Marty, so he is marked as absent. Elvie Barroso.
Present.
Jason Fromowitz. Okay, Jason's not here, so I'm marking him as absent. Sadie Howard. Sadie's not here, so I will mark her as absent. Sandra also won't be present tonight. Neither will Rich Mitz, and neither will Raj Nayar, unless he comes later. Aisha Siddiqui.
Present.
Hannah Singleman.
Present.
Gabrielle Turzo.
Present.
Ronnie White. I do not see Ronnie here, so Ronnie is marked as absent. We do not have a quorum, which simply means that we would not be able to vote on any resolutions officially, if there were any.
Okay. The agenda for tonight's meeting was distributed ahead of time by the board office and is reflected on the screen before you. If there is no objection, we will adopt the agenda. Members of the committee, if you object to adopting the agenda, you may raise your hand through Zoom. Seeing no objections, the agenda for tonight's meeting is adopted. The minutes from the September 8th meeting were distributed ahead of time by the board office. If there is no objection, we will adopt the minutes as drafted. Members of the committee, if you object to adopting the minutes, you may raise your hand through Zoom. Seeing no objections, the minutes from the September 8th meeting are adopted. They will soon be available on the CB6 website. In order to conduct an efficient meeting, let's observe a few ground rules. No one may speak until granted the floor. Committee members, if you have a question about committee business or wish to make a motion, please raise your hand through Zoom. The chat function should not be used for committee business or questions about agenda topics. All such remarks should be made on the record by raising your hand through Zoom. Chat should only be used to alert us to any technical difficulties you are having or to state in writing information that was already stated aloud on the record during the meeting. When a committee member is given the floor to speak, I will identify you and you can unmute yourself so that you can speak. Again, committee members are required by the state open meetings law to have their Zoom cameras on and your first and last name displayed during tonight's entire meeting, from call to order to adjournment. If you must step away from your computer briefly, you are required to leave your camera on. Tonight's agenda, the first one, we will hear from the New York City Department of Health, an update on monkeypox.
Hi, good evening, everyone. This is Pauline Ferranti from the New York City Department of Health. Brendan, I'm going to share my screen really quickly for a PowerPoint presentation on the current status of the MPV situation. So 1 second. Can everyone see my screen right now?
Yeah.
Okay, great. So I will start from the current slide. So just a quick disclaimer, this data is accurate as of today. And also I am not a doctor. So if you have any personal medical questions, I unfortunately am not able to answer any of those and would refer you to speak to your primary care physician. My role at the health department is the Manhattan liaison for the Office of External Affairs, and I have been trained in providing this specific presentation. So as we all know, over the summer, there were cases of monkeypox, or what we call is MPV. And we wanted to make sure that there was good information on our website. And so we put a lot of our data on our website so that it is available to the public. And as of November 3rd of this year, 3,743 cases were reported in New York City. And as we can see, the highest point of transmission was in July, where on one day, on July 25th, we had 97 cases reported. And currently, as of the 7th of November, the 7-day average has been 1 case. So we have seen a steady decline, which we are very grateful for, and we hope to see that continue. So the city, one of the biggest updates that we have right now is that the city is transitioning our mass vaccination sites and pop-up sites to existing clinics that we operate, and that transition will be complete by November 14th. So I'm not sure if many people know, but the New York City Health Department operates sexual health clinics in Fort Greene, Jamaica, Chelsea, and Morrisania in the Bronx. And so we want to make sure that people understand that they can still continue to get the MPV vaccine at our sexual health clinics moving forward beyond November 14th. H&H will also have sites available, and they have 5 acute pride clinics located at Metropolitan, Bellevue, Lincoln, Woodhill, and Jacoby. And so the sites that are slated to close on November 14th are the larger hubs at Times Square in Long Island City, a couple of sites up in the Bronx, and 1 in Brooklyn, and also the H&H facility, the site at Central Harlem and at Gotham. Gouverneurs, sorry, my child just walked out and is distracting me per usual. Every time I start a meeting, he comes out. And you can see the list of the H&H locations here as well. And I'll move on to the next slide. So the total MPV vaccines that have been administered by New York City is actually really, we're very proud to talk about that. As we know, in the beginning of the outbreak, there were some difficulties getting doses, but as the doses became available and as the city really upsurged the availability and the locations in which people can get the vaccine, we currently, as of November 7th, 149,644 vaccine doses have been administered to people who fit within those criteria for eligibility. And we can talk a little bit about who's at risk, although I'm pretty sure everyone at this point sort of knows those basic this basic information, but just to share again, anyone of any sexual orientation, gender identity can get MPV. However, currently reported in the US, there shows that where it was primarily circulating were in networks of gay, bisexual, other LGBT, men who have sex with men, transgender, gender non-conforming, and non-binary people. We were seeing sort of in that, in those social circles, and we were seeing it was more prevalent there. And so we were focused a lot on making sure that our outreach was targeted and making sure that people who were at a higher risk factor were able to get information really quickly. So during Pride, for example, we were out all the time. We were going to clubs, we were going to the Pride Parade, and just sharing information where people might be a little bit more of a higher risk for exposure. So how does MPV spread? It spreads by direct contact with someone who has a rash or open sores. It could also be spread through contact with bedding, clothing, or other items that were used by someone who had active MPV, large respiratory droplets, although it was less contagious than COVID-19 or the flu. But again, there's still other ways in which, it could potentially be spread. And so the experts are still studying sort of different ways in which someone can come into contact with MPV. And again, if you are at a higher risk factor, meaning your immunization or your immune system is generally not as strong, or if you have other, medical factors that might make you a little bit more susceptible, a lot of times we have seen that people are more vulnerable to getting MPV or having the symptoms be much more serious. So symptoms usually start within 2 weeks after exposure. And again, rash and sores all over the body or certain parts of the body are the most common. And again, they can be very itchy and last for 2 to 4 weeks. And typically, right, for most people, these subside on their own. Like a lot of other viruses, it sort of takes your body and your immune system to sort of work it through. But again, we really wanted people to be aware of their symptoms and to make sure that they went to seek medical professionals should they feel like they were exposed. And so with the vaccine availability, we really were emphasizing that people in those risk categories were able to go and be eligible and get priority for the vaccine. But as of the 28th, new eligibility guidelines, people of any sexual orientation or gender identity, who have anonymous sex partners are now eligible. Prior to that, it was a little bit more targeted for folks. But again, we are encouraging everyone who might feel like they are in a higher risk category to go ahead and get the vaccine. Again, taking personal precautions as the #1 way to prevent the transmission or the spread of the virus, but we are encouraging folks to get vaccinated as well. So, again, the recommendations, I'm pretty sure everyone is sort of familiar with, who we recommend to get the vaccine. But again, anyone who feels like they are in a category or are exposed to someone who may also be in the category of higher risk, that we encourage anyone to go ahead and make an appointment to receive the vaccine. So what to do if you have symptoms like any other symptoms of any other illness, we would love for you to call your healthcare provider right away. If you don't have one, you can go on to the city health map. You can go to H&H facility. And again, we really want you to sort of be equipped with this information and be able to share with your primary care physician or, any medical professional that you might be concerned about this specific thing. Because a lot of times if you show up and you just give generalized symptoms, they might not be able to hone in onto something that you are very concerned about. And so we want to encourage people to sort of take agency over their own health and really say specifically, I think I might have been exposed to MPV, and that will then give your healthcare provider sort of a framework or a guide in which they can sort of hone in on sort of what your healthcare needs would be. So again, we really want to encourage everyone to sort of take this information and really educate and empower yourselves with that. So as mentioned, there are in addition to vaccines, you can have other treatments as well. But as mentioned earlier, it's sort of a lot of times people can sort of recover on their own. But again, staying hydrated and making sure that you are keeping your rashes and your sores clean and dry when you're not showering to prevent infection. And, taking over-the-counter medication will also help as well. And just, other ways in which you can sort of relieve the symptoms of the virus. And here is just just a pamphlet that we shared with folks as well. And then we have all of this information on our website. And we really want to make sure that we destigmatize the virus. And so we, instead of saying monkeypox, although it's kind of in your face sort of here, we were shifting towards calling it MPV because we do believe that monkeypox was stigmatizing, and we didn't want people to feel as though sharing this information or having other folks share information and want to ask questions about MPV, that they would feel sort of restricted because they felt it stigmatizing. So we really wanted to make sure people had all of the accurate information, but we didn't want people to feel sort of targeted or stigmatized by the name. So that is my presentation. I'll stop the share now, and I'm happy to take any questions.
Thank you, Pauline. Do we have any question from our members?
I don't see any at the moment, although I do have a question actually.
Yes.
I'm not a member, which is just if there's any updated information on MPV that you would like the Community Board 6 office to promote in its e-blasts and e-newsletters, please feel free to send that to us.
Yeah, sure, absolutely. I will send you just the information about the larger hubs closing and that we're absorbing all of the vaccine distribution to our existing sexual health clinics. I think that would be really helpful for people to know. That way they're not trying to find, or if they come across outdated information, that they're not trying to schedule appointments somewhere where the sites would be closed following November 14th.
Yeah, and the office can also include information on like the clinics that are either in our district or are closest to our district.
Yes, great. Thank you, Brendan.
Thank you.
Pauline, I have 2 questions.
Sure.
Do we have stats about how many cases are in Manhattan?
We do actually. Let me screen share again, and then I will show you our awesome website. Where you can get all sorts of fun information. So let me just go to our main homepage. That way we can start from the very beginning. We have information about COVID-19 boosters as well. So we highly recommend everyone go ahead and get boosted. And then here on our sidebar right here, there is a link to the MPV. And we talk about the name change a little bit here as well. But right up on top, we have data. And when you click on the data, you'll be able to see the cases that I showed earlier, but then it breaks down into borough. So Manhattan, as you see, has the highest case count, and then it breaks it down by age demographic. So between 25 to 34 were where we were seeing most of the cases happening, and then among men in New York.
Okay.
So this is sort of the information that was provided through the data, hospital data, and then here the racial breakdown, and then the sexual orientation. So this was all data that we utilized to inform our outreach and inform where we were really focused on providing vaccines as well. So all of this is on our website. We update it regularly, and I encourage everyone to just browse around. There's lots of really fun stuff on our website.
Okay, thank you. And my second question is that, are we still administering intradermal injections, or we are switching to the subcutaneous?
I don't know that for sure. I do know that we were doing subcutaneous. I believe we were doing subcutaneous. Sorry if I'm pronouncing it incorrectly.
No, we are doing intradermal administered by AP, but once we switch to the DOHMH sexual health clinics, are we still going to do intradermal, or we're switching to subcutaneous?
I'm not 100% sure. I think they were doing subcutaneous only because of dosage issues, and that preserved or that allowed for more doses to be provided. But I actually do not know. So I'm happy to go back and I will find out.
No, allowing more dosage, we do the intradermal.
Oh, through intradermal.
Yes.
Okay.
Because one vial is only one shot for subcutaneous, but intradermal it becomes.
Oh, right. It's in between. Right. It was in between. That's right. That's correct. I apologize for misspeaking. Yes. So I believe there was concern when there were limited doses available and how to be able to, here we go.
Yeah.
Intradermal injections. So I don't know whether or not that is going to change as it slowly moves into our sexual health clinics. I'm happy to ask. But again, as you mentioned, LV, these changes were implemented just to make sure that the supply was able to reach as many people as possible and be as effective as it could be at that time. So I think I will ask, and I will get back to you as soon as I find out from our team at the sexual health clinics.
Thank you.
Sure.
And I think I just have one comment. The new term is MPV, isn't it?
Yes.
But MPV can also mean monkeypox vaccine.
Correct.
Instead of monkeypox virus.
Yes.
So did they say anything about it? It's just a thought.
Yeah, no, I definitely understand. I think when we were talking about the vaccine, then it would be MPV vaccine. But again, I think the intention behind it, as mentioned on our website, really was to destigmatize a lot of the stereotypes surrounding MPV. And we really wanted to make sure that people, did not feel targeted or stigmatized by the label or by the name of the virus. And so I think that was sort of the intention behind it, in respecting and understanding that certain people and folks might feel very stigmatized by the original name.
That's true. All right. So do we have any question from other members?
I see
Brenda?
Gabe has his hand raised.
Okay. Gabe?
Thank you for recognizing me. I'm curious if we have any idea if we can tease out the effect of the decrease in cases between The timing is looks like the vaccine came out at the exact same time when the cases peaked, and I'm wondering if we have any best guesses as to what drove the decrease, and is it worth exploring? Like, is it behavior and public knowledge, or did we vaccinate enough people to actually break the curve like that, or is it just because it's a disease with a relatively low R, so we could expect it to burn out? And like, is there value in sort of pursuing what drove the peak?
Yeah, I mean, I think there is value in that. I don't know whether or not we have specific data to support any hypotheses on it. I think, it could be a combination of the fact that the vaccines were being provided and readily available, and in addition to the health department really focusing a lot of the, information on very specific groups of people who might be at higher risk. So it could be a combination of things. We're not 100% sure, but I can go back to our data folks to see if they have been sort of, working through some of the information that they've received and if they can make any sort of educated guess as to what was the most helpful in driving down the numbers.
That'd be terrific. Thank you.
Sure.
Any other question from the members?
Yeah,
I see Jason has his hand raised.
Huh?
Jason has his hand raised.
Oh, Jason. Jason?
Yep. Hey, so sorry for being late. First of all, I got the time wrong in my head. I missed the beginning of this, so apologize if this was already covered. My question's around the current status of promoting the vaccine and what, if any, populations are being targeted for that at this point. I know that the eligibility criteria expanded.
Sure, I can.
Yeah.
Yes. Yeah. So we had a small slide on that particular thing. So eligibility did expand. Again, focusing on people who may have anonymous sex with, same-sex partners. But really at this point, if you feel like you are exposed or are at a higher risk factor of exposure, we encourage anyone to go ahead and get the vaccine.
But there was a pretty active effort on getting the word out about vaccination, in August or so.
Yep.
Is that still happening, or that's really slowed with the reduction in cases?
There isn't as much. It's not as aggressive as it was over the summer. I think people who we partnered with, community partners, and very specific groups of folks that we worked with. I think we've gotten that information out to as many people as we think needed that information. So I don't know if we're going to continue going out. Like I mentioned earlier, we did go to Pride. A lot of Pride events. We went to bars and clubs just to share information as well. I don't believe that we're continuing to do that very specific type of outreach, but we are still encouraging folks to go and get vaccinated, and we share this information as often as we can. And we encourage everyone to go onto our website as well, just to get the most updated information. But in terms of, very specific and aggressive outreach, I don't believe that is still happening.
Thank you.
Sure.
Okay, so thank you so much, Pauline.
Thank you so much for having me.
Okay. So now we're gonna go to the second agenda, which is a presentation on the health equity and access to care study at the CUNY Graduate School of Public Health.
Thank you.
Should I introduce you, Dr. Romero?
It's okay. I could take a second no need for a formal introduction. But I am at the as it says here, CUNY School of Public Health and Health Policy. We're located in Central Harlem at 125th and Lenox. And excuse me, I'm in the Department of Community Health and Social Sciences. I I'm leading a relatively new project, which is what I'm really happy, and grateful for the opportunity to share with you today. I just do want to mention that my colleague, who's our new coordinator on the project, Samantha Wexler, I think may have to leave soon, and she was just really going to observe, so just in case she has to sign off. But similar to Pauline, I do have a couple of slides. I hope you all can see that. And let me just move something out of the way so you could see it a little better. Okay, so I think I only have like 5 or 6 slides, and it's to give you backgrounds, but I certainly don't want to sort of do a lecture here. I'm really most interested in sharing some information on this relatively new project, and then also, more importantly, get your feedback. Certainly any questions, but any feedback and suggestions you have, because it is a fairly new project, and we're looking to really have a lot of community engagement as we go forward. So as you can see here, it's called the Health Equity and Access to Care Project, and it is a focus group project. Just by way of background, this is a project that is funded by the health department. So Pauline's here from the health department. It's actually in collaboration with folks in the Bureau of Equitable Health Systems. And what happened was last year, health department analysts conducted a small internal study looking at New Yorkers' use of hospital services. And what they did was they used a data set that has discharge data from hospitals. It's not just hospitalizations, but it's also, ambulatory care, same day care services. And they went in with a fairly clear hypothesis around an expectation that there was probably differential utilization of hospital care across the city. And their hypothesis basically was supported by the analysis they conducted. So the two main, findings or analyses that they conducted are right here. They looked at individuals' racial, ethnic identity, as well as their health insurance status. And what they found was that African-American, Black, and or Latino, Hispanic individuals, or folks who identified as such, as well as those who either had no health insurance or those who had a Medicaid health insurance plan, were more likely to use public hospitals, H&H hospitals or safety net hospitals. And those who identified as white and or had private or commercial-based health insurance were more likely to have used private hospitals. So their strong expectation of sort of a segregated healthcare experience in New York City was supported by this analysis that they did. And the data that they used were New York statewide data. It's called Sparks data. And even though it's for the state, they were able to do the analysis specifically around New York City hospitals. So based on that, and I will say a little more about the Sparks data, is that it is quantitative data. It has information about patients, for example, demographic characteristics, which they were able to use in these analyses. There's also other data in terms of their diagnoses, treatment, services received, cost, that kind of thing. They didn't explore all of that, but they were able to at least use the information on the hospitals that they receive services from and their racial, ethnic, and health insurance status to do the analyses that I just described. So what those quantitative data can do is sort of support the what is going on, right? Like, are there differences among patient groups with these different characteristics? And they were able statistically to show that there certainly were differences in the hospitals that they were receiving care from. But quantitative data of this kind were not so, great, or for that matter, even possible to explain the why. Like, why is this going on? What might be the factors related to why there seemed to be sort of segregation in access or utilization of different hospital services. And so they wanted to further, examine this qualitatively to get at the why. And that's why I'm here today, because we're partnering together in this work. And what I will say is that just a few years back, I was involved in work with H&H, where we were looking at, it was also a focus group study, and we enrolled specifically individuals who did not have health insurance, who were either participating in the options program, which is now NYC Care, but it used to be called options. So either they were participating in options or they were not, but they were ostensibly eligible to participate. And there was a strong interest in engaging with immigrant communities, largely who would not be eligible for other sources of health insurance, and to explore whether they were utilizing the program or not, and what their experiences with it were. So that's some work that I was involved in previously, and I would say that a lot of the findings from that were taken into account as the program, sort of evolved into what is now NYC Care. And so that's some background work that I've done in this area. And so, this is sort of, I guess, a continuation of trying to examine a little more about the healthcare opportunities as well as experiences that New Yorkers have. So, and with regard to the project specifically, what I will highlight here is that we're in the first phase, and that's why we're doing a lot of outreach and recruitment and information sharing, because we're just at the beginning. And the idea is that we not only want to get the word out, but we also want to get feedback, because things can certainly be modified and changed to best suit what communities across the city think would be the best way to go. So it's not set in stone, and it's very much intended to be in engagement with and responsive to what communities think as well. But the broad approach at this point is that we're going the focus group route, because that is an opportunity to bring folks together with similar characteristics. And in this case, in terms of insurance and their racial ethnic background, because we are interested in this issue of health equity and to what extent maybe issues around racism may be playing out in healthcare. And so we want to be very intentional, as we look into this and we conduct this project. And the health department has committed to at least 2 years in this work. So we just started this past summer, and it's intended to go, through to the summer of 2024. The first phase is conducting focus groups that include folks who either have private health insurance, participate in Medicaid, or have no health insurance, and stratified by different racial ethnic categories. The intention is to build on this and then to move into a phase where we include immigrants, migrants, not folks not born here in the US and who actually may not even speak English. And in that case, we will be prepared to expand and offer focus groups in different languages. In the Health and Hospitals project that I referred to, that we did with different immigrant communities, we actually collaborated with community-based organizations that serve migrant communities, and we conducted the focus groups in 6 different languages. So we certainly would expect to build on that previous work. And then, as you can see here, again, the health department has thought, well, maybe it would be worthwhile to also hold focus groups that engage groups that are particularly vulnerable. So Indigenous individuals, folks that are unstably housed, formerly incarcerated, again, this is all, open to input and further development. And again, I just want to keep reiterating that. But this is the general plan. And just to repeat, we're right here in the first phase. We've conducted about a dozen focus groups thus far. But before the meeting started, and as I shared with Elvie and Brendan, we've been presenting at different community boards and intend to present. We've shared emails, but really intend to present at all, I believe, 59 community boards across the city. This is a multi-year project, and recruitment will continue. It's not like recruit today through whenever, stop, and then it will be ongoing. Okay, and then I think finally, as far as recruitment goes, this just shows, the ways in which we've initially engaged in outreach. We, like I said, I'm at the CUNY School of Public Health. We do a lot of community-based public health related work. And so there are many community-based organizations across the city that we have worked with in other projects. So we have shared information about this project with them. Our partners at the health department obviously work with CBOs as well and grantees, and they have been sharing this information. Again, we're at community boards, have engaged with several of the borough presidents' offices, engaging as much as possible and on a regular basis in different social media outlets, and also attending citywide events in person. And that, again, all of this will continue. But at the same time, we're really looking to expand these efforts. And I would say also that any suggestions along those lines would be greatly appreciated. I'll just mention from some previous presentations that I've made at other community board meetings, some suggestions around parents' councils with the Department of Education, have been mentioned, and other entities. We're also looking at the New York Public Library System and specific branches that have, strong connections to community. But I think, the opportunities for trying to engage as many New Yorkers in this project is really infinite. And so we would love to keep expanding our recruitment efforts. When all is said and done, if all of those phases proceed, we would be conducting over 100 focus groups. So, it's a large project, and we'd like to just, keep things moving. The last thing I'll share at this point, and then I'm happy, to get any answer and address any questions. I want to share the recruitment flyer. I know we have sent this in an initial email as an attachment, but I'll share it here just so all can, let's see if here it is. Okay, this is the flyer. It's a one-pager. We have included it as an attachment in our emails, but also we have a different version of it that is more conducive to be shared via social media, a JPEG version that, if the community board pushes out events and notices by social media, we could share that version. This one, I think, has been shared in newsletters. But it basically goes over the eligibility. Folks have to be residents in the city and either have accessed care at a hospital or tried to. So if folks tried to access healthcare, but for whatever reason we're not able to, we want to hear their stories as well. To have, one of these different forms of or health insurance statuses, and be in a, sort of a legal adult, right? So 18 or older. We do indicate that for this first round, it's folks who feel they can participate in English, but in the screener, they can indicate what other languages they speak, and we will keep that information so that we can circle back to them once we start to offer the focus groups in other languages. This link, which I'll also include in the chat here, goes to a Qualtrics survey. It's about 10 questions, and it just gets this information to make sure that folks are eligible, and most people should be. And then it gets information about their availability, so we can follow up with them and schedule the focus groups. It would be participating in a virtual focus group. Given COVID-19, we're still feeling that that's the safest way to proceed. But if folks do not have the devices necessary and or internet to participate, we also indicate here that we can accommodate their participation on site at our campus. We have a community site that is really welcoming of the community, and we can accommodate them on site and provide for that. And we provide, a thank you gift of $40 for folks, to participate. We try to recognize in some small way, their time, the time that they provide to participate. So this is the flyer. When we're on site, we also, have hard copies. People can scan it with their, mobile phones. They can, we bring a laptop or a tablet with us, and they can sign up using, the device we provide, or it can get distributed through social media and through other electronic means. So I think with that, I'll stop. I'll put the key information in the chat, and I'm happy to answer any questions.
Any question? Okay, Jason has a question.
Yeah, a question around eligibility. So you included that you have to seek care at a hospital. Is that like admitted to the hospital, or would that include things like outpatient facility associated with the hospital?
Yeah, the latter. So many of the hospitals provide clinic services. Just regular a visit to practice or clinics, or same day ambulatory care, or surgical care. So any and all of the above. It does not have to be admitted.
Thanks.
I see the hand of Gabe.
Hi, thank you. So the stakes, what are the stakes here of the differential hospital use? Are we saying that people are getting inadequate care, or are we saying that the public hospitals are being stressed unnecessarily? What is the harm in this differential and how hospitals are used?
Yeah, so I think that's a great question, because one could play devil's advocate and say, well, just because different groups of people are accessing care at different types of providers or hospitals doesn't necessarily mean that they're getting better or worse care. So I think, that is a great question. But at the same time, it raises, this concern or flag, or at the very least a curiosity as to what might be driving this difference. Because just kind of from a scientific perspective, you would assume that unless there's some factor at work, you would assume that it should be sort of broadly distributed. One would assume that, a relatively similar distribution of patients in terms of their racial ethnic background and their health insurance status should be accessing the wide range of hospitals in New York City. So that's kind of the default, I guess, assumption, operating assumption that people would be working with. And then if that's not happening, if it's sorting, and statistically, at least with those quantitative data, statistically, it seems that, people of color tend to be at the public hospitals. Those with public insurance tend to be going to the public hospitals. Are there some barriers are they trying to access care somewhere else? And are there some barriers that are at play? So, yeah.
This might be a silly question, but did the studies control for distance? I mean, is it possible that a mere distance too could be the driver to this disparity? I mean, I suspect they did, but I'm just curious.
I don't know. And I'm going to say from the presentation that they made some time ago, to us as they were describing this kind of project that they would like to be done, I don't recall that being included in the analysis. They're reporting having controlled for, any number of factors. So I think admittedly, they probably would be the first ones to say that it was a very crude, first cut analysis of, okay, this is, different groups, racial, ethnic the variable on race ethnicity, here's a variable on health insurance status. Do they or do they not sort by different kinds of hospitals? And as I said, they found that there was this sorting, but a real complete and comprehensive quantitative analysis would probably take into account a lot of other variables and see if that finding still holds. They did do a lot of in-depth interviews with health department staff and with staff at some of the H&H hospitals, because they wanted to do some preliminary qualitative data collection as well. And I think by and large, what they found was that the staff that they spoke with weren't surprised at all with those findings. They were like, oh yeah, that's what we see all the time, but didn't have much by way of an explanation either. So I think at the very least, they wanted to get it from the horse's mouth, right? To really speak with people who have access to care or tried to access care and see what their experiences have been like. The last thing I'll say is that, just your, for example of transportation, that is coming up a lot in our focus groups, at least, these initial ones we've conducted. And they talk about transportation being fairly difficult, like it is, a barrier to care, or if they want to go somewhere, it's something that they know that they have to kind of struggle with. So it seems like it might be operating in two ways. It might be operating in the way you were alluding to, where transportation is a barrier and they're just not getting to maybe certain places they would prefer. But in other cases, they're going out of their way to go to certain places, knowing that there's, the transportation is going to be a challenge.
I see the hand of, Gabe, your question was answered? Okay.
Yeah,
So
his hand is raised now.
all right, Honey, I see the hand of Hannah.
Hi, and first of all, thank you for sharing all of that. And I feel like this research is very important. So thank you. On the note, I work at a creative think tank in Brooklyn. We've done some health access work in the past, but just some things that worked for us in case they're helpful for you, throwing them out, like churches were a really important place, like community leaders where there's that built-in trust. So I don't know if that's a network. And then also just like local small business owners, restaurants, cafes, barbershops, nail salons, laundromats, all of those can be kind of ways in where there already is that community. There already are those conversations happening. So could be potential routes to explore.
Yes.
Thank you so much. Yes, we, the small businesses, I think, is something that hasn't come up thus far. So that sounds great. Our school being situated in Harlem, we have folks who run this Harlem Health Initiative, and a large group of collaborators and stakeholders that they engage with are churches, is the faith community. So, but we haven't made that step yet. So that's a great reminder.
Yeah. Any other? I think I just have one question, Dr.
Mhm.
Romero. So you mentioned that this is gonna be a quantitative study
Qualitative.
or qualitative? I see. Okay. And
Yeah.
what is the sample size of your focus group?
So if we go through all the phases and all the phases will probably result in about 120 focus groups. A typical focus group is between like 6 and 8 people. We're finding in this virtual space here that it's actually better if there's slightly fewer. So you figure if you have about 5 people per focus group, give or take, in with 120, what is that? 600?
About.
Yeah. So it'll be, fairly large sample size, and then it'll be stratified. We're looking to sort of have homogeneous focus groups, so we can do our analysis by those with insurance, those without insurance, those, so that's how we're how the sampling frame has been designed.
I see. Thank you. Any other question from members? No? Okay, so Dr. Romero, thank you so much for a very comprehensive presentation. So hopefully we can recruit some coming from our district.
That would be wonderful. I did put in the chat, just so everyone here has my contact information and the link to the screener. You can see what it would be like for individuals who are interested. It would be great if I could follow up, I don't know, maybe with Brendan afterward and just reshare the flyer. And I saw that you do have a newsletter, and I don't know if that's something that's possible,
Yes.
just to get the word out to the community.
Yes, we can.
Yeah. Funny enough, I was making a note to follow up with you after tonight about that exact possibility, having something about this in our newsletter.
That would be wonderful. So I'll get in touch with you or vice versa. And again, I just want to thank you all for the time. I really appreciate it.
Thank you. Okay, so now we're gonna go to the last agenda, which is our last agenda is about exploring topics for future discussion and exploring also some outreach activities. So anybody has some suggestion for topics? Gabe?
Yeah, I'd like to look at automotive noise pollution. I know there's some work that's been happening with this in the city council, but it could be a lot more comprehensive. It's about they've done a good job with modified cars. There are laws against excessive honking, but I think they really are not terribly well enforced. No laws against car alarms, which I think is kind of insane that we tolerate car alarms in New York City in 2022. And I would really like to explore the damage done by automotive-based noise pollution.
Do you have anybody in mind that we can invite to do a presentation, or
I've been trying to find some people. I'm still working on that, but I wanted to float the idea first.
Yeah, all right, so we'll put that as one. Jason?
Yeah, I had two. So both of these may or may not be, they're sort of not necessarily only health and human services, but I think there's a health and human service component of them. Okay, so first one, the gray market weed stores that are opening up all over the city. I don't know. I think there's a health concern around that, both that they're sort of like that they're in this gray market, that it's like been legalized, but they're not licensed. What does that mean for the health of the community who are purchasing the products at these stores? I also think there's like a quality of life concern with like the signage and the way these stores are promoting themselves. So yeah, something with that. And then the second idea I had is around, is probably more like a summer thing, but around like health like classes that we might be able to all help coordinate within the community for like free public access, like exercise type classes. I know a lot of other areas of the city have like in parks, like there's a regular free programming. So this might be more of a parks thing or health and human services. I don't know. But yeah, like how we might be able to organize and encourage exercise classes for the community.
I think we had that as one topic in our webinar series. It's not, Brendan, about health classes that are provided by NYU.
Yeah, I mean, that being said, it was more focused on seniors.
Yeah.
While it sounds like what Jason is talking about isn't necessarily just focused on seniors, if I'm
Yeah.
understanding him correctly.
Yep, that's right.
Okay, so do you want to take the lead to explore on that, Jason?
Sure.
All right, good. Okay, Hannah? Oh, wait, hold on. Jason, about the gray market.
Yes.
What specific one is it about health issue about these gray market that you're talking about?
Yeah. So basically, these shops are selling marijuana that's unregulated, but like out in the open. I think we will eventually have legal and regulated marijuana in New York City, or we will. But they're
Yeah.
right now operating in this gray market space. And
Actually, we can collaborate with John with education because he's looking at that when it comes to small stores that are selling.
yeah, that's what I'm referring to. Yeah, these small
Yeah.
stores that are kind of
Okay,
popping up
so-
and actively promoting it.
All right, so can you take the lead on that, and we can collaborate with John under youth and education? Because
Cool, yeah.
that's one of the topic that they're looking at. Okay,
Sounds good. Yep.
Hannah?
A couple ideas. One, with the new legislation in the Senate about New York State as a safe haven for transgender youth and like protecting access to gender affirming care, like there could potentially be interesting conversation there and like setting ourselves up for success of what that would mean and what that would look like if that's the direction we're headed. It could also open up an interesting conversation just about allyship and sort of supporting holistic health for transgender folks in our community in general. So that was one thought that feels timely. And then another thought, and I think this probably already happens, but like general outreach to organizations, nonprofits, advocacy groups, like in our community, and just hearing from them what's top of mind, what do they feel like we should be talking about, could be something to get additional ideas as well.
All right, so for the transgender youth, you want to take the lead on that? Like, think about getting a speaker that we can invite. Okay.
I'll take the lead on that, just confirming, I heard.
Yeah.
Perfect.
Aisha?
Okay, I have a couple. I don't know how we would do this, but I want to make people more aware of their rights when it comes to subway station like security. I mean, just by looking at whenever I go on the train, I use the train a lot. I see cops at every station, and like obviously to address safety concerns, mental illness concerns, homelessness, like all that. But also I want people to be more aware of their rights if they're approached by a police officer or if they need to contact someone if they find themselves in a situation where the like call a police officer, both of those. There is a station on 42nd in Lexington, which is the 4, 5, 6, and the 7, and the shuttle. No, yeah, something like that. No, just the 7. And then I was thinking if we could make like any type of signs, like just for people to know, like it might take a while, but even if we can include it on the newsletter, because it's something that I feel like a lot of people like gloss over. They're like, yeah, like we'll just contact the cops if something unsafe is happening. But if you're in a situation where you have to engage with the cops and you don't know your rights, I want people to be aware of what they can say, what they can do, all of that. And then the other thing is there's been an increase. I didn't do a lot of research on this, but there's been an increase in fentanyl being in like recreational drugs and also just drugs that people are taking. And I want to make it more aware. First of all, if you mix certain drugs with marijuana, which is now legal, it is very dangerous. Even like prescription medications, I think it's like, even like I think Benadryl, like it's dangerous. Like you have to be careful. I want people to be aware of that. And also fentanyl testing strips. But I did the research and I don't think there's a site where you can get it in Midtown, like Midtown Manhattan, like our district. But we could include the sites where you can access it if that is possible.
Okay, the first one, Brandon, do you think we can invite somebody from the police?
So the first item I actually think is probably better suited for our public safety committee, which also deals with human rights issues. So I think for that, the public safety committee, because there's the police side of things, with the public safety, and then the knowing your rights aspect would fall into human rights, which is also the public safety committee. So, Aisha, I don't know if you have the contact information. I can't forget. Are you part of the public safety committee? I'm still getting used to which committees the newer members are on, but if you don't have the contact information for Matt Roberts, who's the chair of our public safety committee,
Yes.
I can put you, Aisha, in the loop with him, because I think your first idea is probably best suited for that committee.
Yes. Okay, so the second one, this is more like drug interaction with, the recreational drugs and some of the over-the-counter drugs, which what we can do, we can explore that. We can probably develop flyers or develop some brochure about that we can distribute in the community. We'll talk about that. Okay, that's a good idea. Any other?
I'm not a committee member, but I have my hand raised just to address.
Oh yes, Brenda.
No worries. Just a few quick things I want to address. First of all, in terms of some of the topics that are coming up, yes, these topics could be ideas for presentations, but they also could be ideas for looking at legislation in the city council or at the state level, seeing whether there's any legislation that would address any of these issues. So just want to make that clear as a possibility. A couple of other random things I'd like to bring up. I know Gabe mentioned something about automotive noise pollution. That is, it's interesting Gabe brings that up, because I recently learned about a study that MIT and Transportation Alternatives worked on spatial equity, that found that our district has the fourth worst noise pollution and air pollution of all the 59 community districts in New York City. So fourth worst noise pollution of 59. So I'd make note of that. And then the other thing I want to just briefly touch upon is Jason talking about smoke shops. Constituents have been reaching out to our office as well as other elected officials' offices about these smoke shops opening up. And it is an issue. And it is something where enforcement has been a challenge, since technically these places are not licensed, and the marketing can be, to put it politely, interesting. Yeah, I just want to confirm from a board office standpoint, since we get a lot of constituent service requests, that constituents have been reaching out to our office as well as to city council and state senate offices about this particular problem.
So Brandon, is that a possible reso to develop?
If there is any legislation on that would improve enforcement dealing with with illegal, these illegal smoke shops, or with certain marketing, potentially it would be the subject of a reso if there's anything legislative that's involved.
That's good. I see the hand of Jason.
Yeah, just a follow-up question, Brendan, on the legislation piece. And sorry, this is like a newbie question. If we were to write a reso, would it be restricted to a reso supporting some proposed legislation, or could it be a reso that was encouraging new legislation?
Yeah,
it could be either one. The committee could go, in either or both directions, depending on what sort of position the committee wants to take.
Yeah.
Cool.
And just sort of to add a little bit of extra commentary, the state legislative session starts in January. So, now seems like a good time to think about all this, because, the new session is starting in January, and, better to think about it now than like in May or June when the session is coming to an end.
that's right. So when it comes to priority, Brandon, which of these can we handle first in January?
That is completely up to you and the other committee members. I will say, though, that if the topic of some of these smoke shops is something you all are interested in pursuing, definitely, it'll definitely be important to make sure that you're in the loop with John and the Youth and Education Committee. And I should also reach out to John myself just to say, hey, the CD6 office has also been getting complaints about these smoke shops.
That's right.
Just for his awareness.
Yep. I think I see the hand of Sadi.
Oh, yeah, I was wondering with the legislation about smoke shops, because a lot of the discussion I've seen around it, especially with those people from yesterday from the youth smoking prevention, would it be targeting smoke shops that are located near middle and high schools, or just in general from throughout the city and our district?
It should be within our district.
Okay.
Brandon, what do you say?
Um, so the problem right now is with specifically unlicensed smoke shops, some of which are near middle and high schools, some of which are not. Um, so I would say both and, but specifically focusing in on unlicensed smoke shops.
They're
because-
all unlicensed at
Yeah,
the
yeah.
right?
yeah.
Mostly are
Yeah,
unlicensed.
mostly are. When as the what's it called, the Cannabis Control Board or something like that, as they get more into place, they will be granting certain licenses. But yeah, there have been a lot of unlicensed smoke shops opening up.
And it seems like we're
Um,
like at least a year until we'll see licensed smoke shops. So yeah.
That's what I've been hearing.
Aisha?
I'm on the youth and education committee, and we were also doing something like this where we wanted to bring up certain topics that new members or old members wanted to discuss, and a lot of it was prevalent around smoke shops and smoke shops around schools. So if we also were just talking about that, we're gonna mostly public schools. Baruch, we were gonna talk about Baruch. There's this smoke shop right next to it, and parents have been giving complaints. So if you can always contact the chair.
Yeah, we can have a joint when it comes to that topic.
Yeah. And as I said, I'll reach out to John just to add my little bit of commentary, because the office has also been getting complaints about smoke shops.
Wait, what's the licensing that needs to be needed for smoke shops? Because I know like underage kids can work, well, not underage, but under 21 can work at smoke shops. So what's the licensing just to make sure that the products are real and all of that?
Well, don't quote me on it because I'm not an expert when it comes to licensing, but at least with the marijuana piece,
Yeah.
you'll ultimately places will need a license with I forget exactly what it's called. I think it's the Office of Cannabis Management or something like that.
Yes.
I'm just checking the name of it. The Office of Cannabis Management. So, at least for the marijuana piece, ultimately a license with them. But unless they're moving more quickly than I realize, I don't think they've granted any such licenses yet. But they will be doing so in the coming months, I'm pretty
Okay,
sure.
so you're talking about cannabis. You're not talking about vape products. Like all of those have, well, not all, but most of them we're thinking have their licenses.
Yeah.
But we're addressing cannabis. That's the thing. Or both.
And that's certainly part of it.
Okay.
That's not it, but certainly part of it.
Okay. Got it.
My guess is the community concern around it is on like mostly on the signage rather than the sale, if I had to guess, or at least maybe that's my primary issue with it.
You said something other than the
signage,
sale?
marketing, yeah.
Actually, it's been more with quality of life concerns. There's this sort of unsavory activity or that sort of unsavory activity. So, it's been primarily around quality of life.
Okay, interesting.
And availability of it.
Yeah. Not
Available.
that the signage isn't an issue, especially if it's signage that looks interesting to kids.
Yeah.
But the people who contact us, it's about quality of life concerns.
Okay, so any other topics? What about outreach activities for 2023? I think Sandra, let me see if I can find Sandra gave me one. Yeah, I think for outreach activities, Sandra suggested an outreach to vulnerable members of the community when upheavals hit, like the one that we just had, the COVID or hurricanes. So she would like our committee to consider how we can be fulcrum in promoting such outreach programs in our community. Any other suggestion for outreach? Well, you can
I
think
see
about-
Hannah's hand is raised.
Oh, Hannah, yes.
I just have more of a question. Ellie, would it be, or would have been like successful outreaches in the past for the board? That might just be helpful for me to then think about other options too.
Not really outreach, but we had a health fair, which I'm gonna talk about it under new business.
Okay, perfect. Thank you.
Okay, so what you can do is if you think of outreach activities and just make that suggestion to me, and we can discuss that in our next meeting. Okay, and so now we are heading to my report. I do not have report, but I want to talk about new business. So I would like to propose a health fair in May 2023. The last time we had organized a health fair was in 2019, just before the onset of the pandemic. And the purpose of the health fair was to provide preventive services. So we provided screening, immunization. We had brochure to raise awareness of health risk, and also promoting healthy habits and other community resources. So at that time, our target audience were the older adults, the seniors. But this time we can organize another health fair in 2023, and our target audience can be young and older adults. It can be students residing in our district. And the last time we did it, it was held at the Baruch facility, but it was quite small. So this time I'm thinking that we can explore for a bigger venue. And for this new business, new project, I would like to get 2 volunteers from our members to take the lead. And no worries, I will be there to guide you. So, any volunteer?
Wait, when would this be?
I'm thinking about it should be like May 2023, May or the latest in June. But if we decide to do this, preparation should already start now, like looking for the venue. We have a list of partners. So not Brandon, we still have the list of the different organizations that participated with us, like NYU, Bellevue.
Yeah, I'm pretty sure so. I would need to, I don't know how much things have changed since before the pandemic. I mean, NYU and Bellevue obviously are still around, but I'm pretty sure we have a list from that.
I would like volunteers from the new members.
I'm happy to be involved. I don't
Thank
know if I want
thank you.
to the whole thing.
Yeah,
but
Me too. I don't want to do.
At least two. I need 2 volunteers.
I'll volunteer, but I need to know like the commitments for it, like what exactly I need to do, what exactly is necessary.
I think what's gonna happen with like whoever volunteers, I'm gonna meet with you so we can plan and we can plan about it and guide you on what to do.
Okay, so
Brendan?
I'm happy to put my name out there too with the, I just know nothing about what it entails, but I'm
No
happy
worries.
to help and add where I can along with the others.
No worries.
So
I've
how
been
often-
doing this for not just with community board. I've been doing this with the health department for almost 20 years. So no worries. I just wanted you to take the lead because I have so much in my hand. I need buddies to work with me. All right, so Jason and Hannah,
I can also do it.
and Aisha. Okay, thank you. Thank you so much. Okay. Anything else? Any other new business from our members? Any old or new business?
What do I do for minutes?
So for minutes, I'll, probably on Monday, we'll send you
Okay.
everything.
So later.
Brendan will send you a template.
Thank you.
Yep, as well as a recording of tonight's meeting, a transcript of the meeting, and presentations. So we'll make sure you have what you need.
Okay, perfect. Got it.
Okay, so any other questions? Any other other business?
I do not see any hands.
No hands. So I think, Brendan, it's time. We seeing no further business. The meeting is adjourned at 8:04.